welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Cam Deemer, president of DrFirst, which provides e-prescribing and other platform services to providers, payers, and other healthcare system stakeholders. With over 20 years of healthcare experience under his belt, Cam is a strong proponent of interoperability and has worked to improve business processes as well as technology strategies in service to that goal. Welcome, Cam, and thanks for joining us.
Hi, David. Thank you for having me today.
A pleasure. So, Cam, different people use the word interoperability to mean different things in our industry. What does that term mean to you?
Yeah, interoperability is actually a pretty big topic. I give a lot of credit to the federal agencies that have taken a swing at this, CMS, ONC, even the DEA getting in on it to try to find ways to free up information, make sure that it gets in the right people's hands at the right time. The state governments have been involved in it, through getting together the controlled substance registries at the state level, make sure providers have access to that information when they're prescribing opioids. Vendors are all over it with everything from patient portals to shared databases, information exchange among all users of their platforms. And even, more recently, the FHIR interfaces that people are implementing to let third-party vendors have access to information. In the broader sense, it encompasses everything from the giant federal initiatives to try to get people to share information in consistent formats to the kind of things we do that are much more focused. But I guess in the sense of what does interoperability mean to me, it means making sure the people who really need information get it when they need it so that they can collaborate effectively around patient care.
Okay, I'll take that. As you described, there are a lot of people talking about interoperability, and in a sense, it reminds me of a perhaps inappropriate joke about teenagers and sex. Everyone's talking about it, nobody really knows how to do it. And sometimes the more they're talking about it, the less they're doing it. I'm just wondering where you feel we are on that continuum when it comes to interoperability. One thing that comes to mind for me there is when we first started the whole journey to meaningful use, I think there was a misperception in some quarters that interoperability was baked in from day one, and it really wasn't. Mm-hmm. Where are we really on the road to interoperability? What are you doing? What's your company doing in terms of advancing that goal?
Well, our take on this is that the top-down solutions, like I was mentioning earlier, are great, but they have a very long time frame for implementation. They tend to be very expensive. And the thing that always catches our attention around regulation is the way it favors inertia over innovation. You build what you have to build. Everybody builds the same thing. And unfortunately, that leaves gaps. It's hard to regulate in a way that you feel like all the little connectors that tie interoperability together. We believe there are trigger points or specific workflows that can keep this overall effort toward interoperability from really meeting its promise. We're trying to create better, safer care. We're trying to lower costs. But if all the pieces don't hang together well, which I think is partially what you were talking about with meaningful use, you actually end up with something that looks good, but maybe it doesn't quite do what you thought it was going to do. You gave a little illustration. Let me give a little unrelated illustration. I own a Jeep. I like to off-road. A couple years ago, I was way out in the backcountry of Arizona, and I was kind of subconsciously hearing this ticking sound. And by the time I was heading home on the highway, it was becoming much more obvious. It started out like ticking, and then it became chirping, and then it turned into squealing, and I was getting pretty worried about it. I finally got home. I took a look, and I found out the problem was this universal joint on one end of the drive shaft. And when I took it apart, there's these little tiny needle bearings in there that are so small that if you accidentally dump them on the garage floor, which I might have done, they're very hard to find. And what was happening was they were grinding themselves up. So these tiny little bearings that weren't working right were just about to cause massive drive shaft failure, and then the whole Jeep wasn't going to be able to run. And that's basically what happens with interoperability, I think. There's many little workflows that if they aren't done right, then you don't really get to your goal of being able to really share information well. So that's one of the key things we focus on as a company, noticing the gaps, addressing them in simple and powerful ways so that the bigger goals of interoperability are possible. Philosophically, we're really focused on what we think of as a triangle of care. Doctors at one point, hospitals and post-acute at the other point, things like hospice, long-term care, stuff like that. And then pharmacy on the third point. And those three entities just interact with each other constantly. And making sure the workflows between them are really smooth is extremely important to interoperability. In the center of that triangle is the patient, and all three of those quadrants interact with the patient as well, and the patient interacts with all of them. So those workflows need to be really good. And then around this whole thing is a big cloud of all the other people, the payers, the PBMs, pharma, durable medical equipment, labs. I mean, you can go on and on with all the people who have something to say about healthcare delivery. Mm-hmm. And real interoperability would mean that those three entities in the triangle of care, as they're seeing that patient at a point of encounter, they're getting exactly what they need from everybody else. It doesn't do any good to have the information when the patient's not there, but when the patient's there, it makes a lot of difference. So we think it's important to work on all the little things that make that possible, because the big things are already being handled by the regulation, and now you just got to do the pieces that make it all hold together.
Your company started out in the e-prescribing space specifically, is that right?
We did, and it's a common misconception that we're an e-prescribing company or an EMR. And in fact, we turned our backs on that almost 20 years ago and decided instead to really focus on healthcare IT platforms. Mm-hmm. Today, our platforms are used daily by about 300,000 healthcare professionals, of which about 110,000 of those are prescribers. 1,400 hospitals have implemented our services, and about half of the EHRs in the country. Mm-hmm. So we're pretty widely distributed. Some of the things we're trying to address right now in interoperability, everything from when a provider's trying to prescribe opioids and he's being required to check the PDMP. PDMP means Prescription Drug Management Program. Mm-hmm. We move that into prescribing workflow. So the goal of interoperability, of making it available, becomes real because the provider gets it as part of what they're doing anyway. We make sure patients get cost information on drugs before they get to the pharmacy. We make sure providers have a mobile prescribing solution that doesn't require them to VPN into their EMR so that they don't do it, and instead they drop back on phoning in scripts or writing them on paper, which just gums up the works with pharmacy because they expect everything in an electronic format these days. There's three things I think are particularly interesting right now. One is some of the counterintuitive work we're doing on telehealth. One is some of the advancements we've introduced around machine learning and AI and applying that to medication history. And we're doing some really neat work on price and quality transparency on the medical side of spending, where previously we'd mainly worked on the prescription drug side of the industry.
Well, tell me what you mean by counterintuitive work in the world of telehealth.
There are people doing great work in telehealth on the patient side of the equation, meaning that a lot of money has been spent helping develop systems that allow patients to replace an office visit with a telehealth visit. They can schedule an appointment, pay for it online, those kind of things. What we're really focused on is the piece that hasn't been addressed, which is the provider side of this. You can imagine you're a physician, somebody comes to the office, you do an exam, you prescribe a therapy or a treatment, and you send them on their way, and then you want to follow up, see how they're doing. Well, you could call. That has a set of problems, including not being able to really see what's happening with the patient. But we have recently implemented in our secure collaboration platform telehealth capabilities, so a provider can initiate a telehealth conference with a patient as opposed to the patient initiating it with the physician. So that lets the physician maybe take a look at a wound, maybe check on a rash, maybe just be able to see the patient's body language to see how they're feeling, how they're reacting to whatever their therapy was. So it gives a physician another tool that's different than talking on the phone or scheduling another visit. And you can see how this would be also really helpful with EMS workers when you arrive on the scene of an accident, to be able to quickly initiate a telehealth conference back to a provider in whatever hospital you're going to transport to, and be able to give them a quick view of what's happening and consult that way instead of trying to just work back and forth on a radio. So that's what I meant by counterintuitive. We're working it from the opposite direction and trying to fill a gap that was left by what everyone else is doing right now.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Cam Deemer, president of DrFirst. So, Cam, you listed a number of different things we're going to delve into. Telehealth was the first of those, and I'll ask you to just keep going here.
Yeah, I thought it would be interesting to talk a little bit about medication history. This is like a really important part of interoperability, making sure that, for example, when a patient is admitted to the hospital, that the hospitalists have a good, complete record of what they call their home meds, the drugs that they're active on when they're admitted to the hospital. Then that has to be reconciled with whatever therapies will be provided in the hospital. And then when they go back out, you have to have a good record of what they were on when they came in, so you can restart those therapies or discontinue them or whatever.
Classic brown paper bag problem.
Yes, it is. So on the front end of that, the old school way of handling it was you debrief the patient, you debrief the caregiver, you deal with all the uncertainty about what I'm really taking, about who I got it from, about where I had it filled. They're not sure exactly how much they should take. They often modify their therapies and don't share what they're actually doing. So some work was done on this probably 10 years ago now, when SureScript introduced a medication history feed that was available to hospitals and available to vendors like DrFirst to improve on and resell. Many people in the industry have adopted this standard industry medication history feed, but there are significant problems with it that make it work not that well for hospitals. Typically, there's three things that make a good med history. You want to be able to find nearly all of your patients when you ask if there's a med history for them. You want to have a complete set of records for each patient. And then the one that's often overlooked is the data has to actually be usable by the hospital. And what I thought was interesting to chat about related to interoperability is that although a lot of data is flowing back and forth, it's not always usable by the recipient. What happens with medication histories, if there's no change to it, is when the hospital receives it, it generally comes in as free text. And different EHR vendors put different information in that field. They put it in different orders. They use different words. When it comes into the hospital and the hospital has to interpret that for their system, there's a big problem. What many of them fall back to is a technician on the hospital side has to just read the free text and then retype it into the hospital system, which is another example of, sure, it's interoperability, but that's not really what everybody wanted, right?
Right.
So free text is one hurdle. Mostly the information is missing SIGs, in other words, the instruction. So if the SIG is missing or if part of the SIG is missing, somebody's got to make a phone call to the doctor or the pharmacy to find out, well, how is the patient supposed to be taking this? Another problem is nomenclatures are different. The EHR vendor might say take orally, but the hospital database might expect take by mouth. Or one might be using Latin abbreviations and the other one standardized on English words. So again, the data, when it's brought in, has to be translated manually or just imported untranslated, and then the hospital systems can't use it for clinical checks or analytics. Another problem is NDC, the drug code, the identifier for each individual drug. Depending what compendium you've used, First Data Bank or Medispan or any of the others that are readily available, you may have problems with obsolete NDCs. It may be that the hospital's on a different update schedule than the EHR that created the record. So you often run into mismatched NDCs, which cannot be imported into the hospital system in a meaningful way. What we were able to do recently was create a patented process where we applied machine learning to enormous numbers of these med history records, and the AI learned to cut apart that free text into the individual fields that the hospital systems need, and at the same time translate the nomenclatures into the nomenclature used by the hospital. We can add additional NDCs, additional drug identifiers, so that we're much more likely to find a match on the hospital side. And you end up with records which were virtually unusable automatically, instead being able to import 93% of your records because we've been able to use AI to clean that up. So it's kind of exciting to see, the promise of machine learning and artificial intelligence when you can apply it to simple but critically important processes to make everything work with interoperability.
That's very encouraging. So how long has that feature been available to your users?
A couple years ago, we implemented the first version of it, and we got pretty broad distribution with that. But recently, we introduced a new generation of AI, and we improved our results dramatically. So we got, I'll say, another 15 percentage point improvement in our ability to translate records. Mm-hmm. So it's been several years now.
I imagine the years of experience add to the knowledge base of the AI to be able to do the work a little bit better each time.
Yeah, it does make a big difference, and we're learning how to apply the AI to additional problems as well. So we call this SmartSig, and SmartSig 2 addresses additional issues that SmartSig 1 wasn't smart enough to address.
Okay. And what sort of certifications or regulatory reviews do a tool like that have to go through?
Currently, medication history is not one of the systems that is regulated in that way where there's a specific certification. We recognize that it would be very bad for artificial intelligence to be incorrectly correcting these records or incorrectly cutting apart the free text. So whenever our system can't make a clean decision, we default to doing nothing. We only act on records where we're sure we can actually do it correctly. We have a team of clinicians that regularly reviews the output of SmartSig to make sure that the output makes sense against the input that it's receiving. And when we present it in an actual hospital setting, we give the hospital technicians or nurses, whoever is doing the MedRec, we give them both the original free text and the interpreted version of the free text. So I think the last thing that we were talking about was applying some of the platform technologies that have been implemented for a while on the pharmacy side into the medical spend side of the equation.
So tell me a little bit about what do you mean by that?
One of the things that's been interesting about healthcare, I actually started my healthcare IT career at a major PBM. So I was working with prescription benefits, and the PBM industry actually started automating their processes as early as the late 60s. Pharmacy interoperability and automation has always led the medical side. But we believe now is the right time to start moving some of those solutions over to the medical side of the industry. So, for example, for many years, we've been offering to physicians drug pricing, real-time benefit check. So whenever a physician selects a drug and a pharmacy, we will check with the payer who's going to pay for that claim, run it through a real adjudication, and come back with exactly how much that's going to cost the patient and whether there are any restrictions involved, around prior auth or quantity limits, things like that. And then present the physician with some alternative drugs and the pricing for those and all the same information. It helps the provider make an informed decision. And really, that's interoperability as well, right? Because the information they need that's locked up at the PBM and was only available previously when a pharmacy claim was submitted has now been freed up and put right in the physician's workflow.
Right. That's a terrific advance. Just as you said, it used to be only available once the claim is adjudicated.
Right.
The same thing could be said of pretty much all health billing, right?
Yeah, that's exactly right. So,
people talk about going to a restaurant where there are no prices on the menu, and you don't know what your dinner's going to cost until 60 days later.
Yeah, and you better hope the restaurant's in network or it's going to be 3 times as expensive.
Right. Do you see an opening? I mean, I remember hearing about a company a number of years back that was trying to do something similar, feeding in information from particular health plans and lining that up with individual patients and individual facilities to be able to give people pricing information up front. But I sort of never heard about that again. Do you see that kind of work expanding?
I do. We have been partnered over the last year with United Healthcare to work on a platform that United calls Point of Care Assist. United's been very visionary about this. They created a whole bundle of APIs that allow DrFirst to access information within their payer systems and bring that out to the physician on the medical side. They're already doing this with us on the pharmacy side, and working together now, we're bringing the same kind of information into the medical side of the industry. So when a physician is trying to determine a care plan for a patient, they can now retrieve pricing information depending on who they're going to refer to and what the procedure is that they're seeking information on. They can receive information on quality of the provider they're referring to, or be given a choice of providers at different quality ratings. They get real-time information on medical prior authorization, and they can deliver gap in care messages to the physician. So in the event the physician has skipped something that the payers identified as important for that patient, they can remind them to make sure they do that, which is good for the provider as an opportunity to work with the patient, and as well as for their participation in incentive programs that UHC has, but also really good for the patient to make sure that nothing's being missed as part of their therapy.
Right. So right. It's not just about price and cost, but it's also identifying
quality of care as well.
Gaps of care, quality of care. Great.
Yeah, so there's a number of services that UHC is moving forward with rolling out. In the meantime, we're working with them to gain distribution for the platform. By the end of last year, we had about 45,000 physicians with access to the first set of APIs through their EHRs. That's as part of our platform. This year, we'll continue to expand both the number of providers that have access as well as the number of services that are available. We're talking to a number of other payers about joining in and creating APIs into their systems as well, so we can end up with a multi-payer platform, and physicians will have access to information they've never had before. On our side, we call it Care Complete because we're rolling in both the pharmacy and medical side together. But I did want to give a nod to UHC for their forward thinking with their Point of Care Assist program.
Great. Very interesting. So for my lightning round wrap-up question for you, Cam, I'll ask you this. If you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or expect to find has changed dramatically?
Is this the question where I have to wager some of my money and then we see if I win in the end, or?
Yeah. Door number 3. We'll get you a new Jeep.
Well, that'd be nice. You said 5 years, right?
Yes.
If you gave me a 7 or 8 years, I would have said, gee, that's enough time that maybe serious people would make serious progress on, the crushing cost of healthcare. But I don't think that's going to happen in 5 years. I think in 5 years, it's going to have to be something we've already started, because 5 years goes pretty fast. A couple thoughts. Something I actually don't have much to do with, but I think is fascinating. I think within 5 years, we're going to be like right in the middle of a big discussion about how to handle cures as opposed to therapies that postpone disease. I think we'll be talking about how they're going to be funded, ethical decisions about access, the impact on society and economies. I think that's a fascinating thing that's going to be happening within 5 years. But the one I actually might be able to do something about that I think would be really cool and wake up and see, I think 5 years is enough time that we might be able to quit talking about involving patients in their health care and actually have them meaningfully participating. I mean, if you think about what people have done to date, asking patients to learn enough about healthcare to participate is just nuts. It took me 20 years to even have a working knowledge of it, to be able to, think about patients. They're trying to understand disease at an expert level so that they understand treatments, they understand all the technical jargon around, risks and efficacy. They got to understand how billing works. They got to understand payer structures, network contracting. They'd have to understand how appeals work, how therapy can be blocked with prior auth and quantity limits, how formulary status matters, copay structures. It takes decades for people to become adequate in these areas, and we ask patients to, step up and be part of making decisions, and they don't know any of this. Healthcare for patients is episodic. For you and me, it's a career, right?
Right.
So I think in 5 years, that's enough time to help us develop the tools that give patients the information they need when they need it instead of expecting them to be experts. It's enough time to be able to simplify for them how coverage and payments work. I think it's enough time to bring full cost transparency and information about alternatives in language patients can understand in a format they're ready to accept. And if we can do that, if we can demystify all that, it might be possible to create like real patient engagement and not just talk about patient engagement. So I would love to wake up in 5 years and found out that we made a big dent in that problem.
Well, that's an ambitious agenda, and I would like to share your optimism in achieving that over the next 5 years. Thank you again for joining us.
Hey, David, thank you for the chance to talk with you. I enjoyed it.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.